We've all heard the saying, rob Peter to pay Paul, right? Well, that is how I would describe one of the procedures, still, I think, far too common in the vascular world for peripheral artery disease. We have Dr. Lily Johnston here, and this is NextGen MD. We're talking about femoral to femoral bypasses. Dr. Johnston, what do you think about my introduction there? A Fem-Fem bypass, a little bit of robbing Peter to pay Paul?
Right. So the idea behind a femoral-femoral bypass is that you are basically borrowing some of the blood flow that was going to go down one leg, call it the left leg, and are going to swing that over across the hip bones and bring it over to the right side. And this is usually because the iliac artery above on that right side is blocked. And so this is our way to, it's called an extra anatomic bypass. And what that means is that this is not your own native anatomy. This is us rearranging plumbing in a way that, God never intended for it to go, but it works at least for a period of time. And it can get you out of a tough situation when the limb is threatened.
But in my experience, I have two issues with it. One, if one leg goes down, if that good leg goes down, both legs, in my experience, we've had go down with patients. And then number two, I can't tell you how many patients have come to us where it's kinked. And not one of the doctors had ever told the patients to watch what they do, no squatting. There are some other things that one of our patients was just told recently that she needed to watch out for and having this fem so that it would not kink and go down. So I'm curious your thoughts on the failure rates for the fem procedures.
I don't think that, so the failure rates are reasonably high. I forget exactly what the number is at 5 years, but extra anatomic bypasses are all, and this is like axe to femoral bypasses, femoral bypasses, all of them, for many reasons, are subject to much higher failure rates than their normal anatomic configuration. So that would be an aortofemoral bypass would be the normal configuration to restore what we would call inline flow to the leg in the same flow pattern, right, that your own arteries had. And part of the reason is that these are all synthetic tubes, so they're not your own veins. The veins are not big and strong enough to be routed around in these unconventional places for a bypass. So the Fem-Fems or the Axe-Fems are all going to be PTFE or artificial plastics, and many of them are reinforced with little rings on the outside to help prevent the kinking. But of course, again, the arteries in the body are typically placed in such a, or they're configured in our own anatomy in such a way that they're pretty protected from compression or bending. The extra anatomic bypasses are usually fairly superficial in terms of where they are relative to the skin. You can often feel them underneath the skin. And that means that if you bend your legs in a certain way or you sleep on your side in an axe-fem or something like that, you could compress the graft enough to shut it down. And that's, again, those rings on the outside are supposed to help reinforce it and prevent that from being common, but it absolutely happens.
I mean, you get a kink at a fire hose, so I mean, in a
Yep.
water hose. So,
Yep.
I mean, you could only imagine. And you did mention, we are talking about the kinks. And so the vascular surgeon told her no squatting and no pulling her knees, no sitting and pulling her knees up to her chest. Do you have any other words of wisdom or warnings for people in terms of if they do end up with a fem?
I, you know, it's all about the duration, right? So if you just squat down to pick something up real quick and stand back up, obviously you're not going to block that whole thing off completely forever. It's a question of duration as well. But yeah, especially in thinner folks who have less padding in terms of anything that will alter those pinching motions.
Right.
Um, the thinner you are, the more likely you are to compress a graft with just sort of regular day-to-day activities, unfortunately. And the more acute those angles become as we move. So that's, again, I wouldn't ever say that this is like a patient education, like, or a patient's fault, but certainly we can have things that are more likely. I see it in patients who have stents behind the knees too, and they like want to go gardening on their knees. And they're like, okay, but it'd be great if you didn't spend a lot of time just like in that kneeling position with the knee flex. Like minute to minute, it's fine, but I wouldn't stay in that way for a long time if you can help it.
And that's exactly actually what the vascular surgeon had asked her. He's like, "Are you a gardener? Do you spend a lot of time, on your knees or squatting down and planting, seeds?" And
Yeah.
she said, "Yeah, how did you know?" And he said, "It's a pretty good kink in there. Oh, just say no. Don't do it."
Yeah,
Um,
at some point, hiring somebody to do the stuff in your like on the floor garden beds is going to be going to be helpful. I wish I also came to that from experience with another patient who gardened.
And we've had really great success with a few cases with the Fem-Fems, and the Fem-Fem really was in each of the cases that I'm thinking of right now were part of grander reconstruction. Like they were really complex cases, hours and hours, a lot of things that were involved, with the iliacs and such, and so they couldn't get around doing this.
Hmm.
But are there for the general ones that I see quite often that aren't as complex? They may just have a blocked iliac artery. What are some of the questions to ask the doctor to understand if there might be another option? I know that every surgeon I've talked to has said, "Oh no, I'm not going to do an aortofem. I do an aortobifem. It just doesn't work the same." What are your thoughts?
That's an interesting point. I hadn't really thought about it. I'm not sure if I can remember doing or like having a bad outcome with an aorta uniiliac.
So it is
That's
possible.
I mean, anything is possible, but I'm trying to see if I can answer the question, are the outcomes worse? And I don't know that I know the answer to that off the top of my head, actually. It's not occurred to me that that has um, been more problematic. I've certainly done a unilateral axe-fem bypass, um, but I don't know if I have ever done an aorta uniiliac. I'm not sure. It's a great point. I'm not sure.
Yeah, I just was told that nope, not an option. But in most of the other cases, I was able to get the patient to another doctor that was able to navigate through the iliac. And most of the cases were cases where, which I thought was interesting, where they didn't even do an angiogram ahead. They looked at the CT angiogram and were like, "Nope, nothing can be done. So we're just going to go ahead and do this fem-fem." They just thought it was the only
Hmm.
option. So we, always say getting second opinion. But I had asked several surgeons, "Well, can't you do an aorto? You're calling it a unifem or uniiliac?"
Yeah.
Um, and they were like, "No, it just doesn't work as well." I'm like, "Oh, okay." But of course, I'm not a doctor, so I don't know. But that's something that we should look up for the future just because we have one patient in particular thinking about, and she's not smoking anymore. Yay. But,
Yay.
might have been a little too late. So maybe the fem-fem is the only option for her. But how does she know? What should she ask to see? I mean, should she ask this particular surgeon, because we haven't asked him yet, if the ortho um, iliac procedure is a possibility for her?
Yeah, I would say, if you have one side of your iliac open, it gives you a lot of options to try to revasc endo. So, if you're thinking about one occluded iliac, your options are to come from below that iliac on the same side and try to get up from the bottom. If your other iliac is open, then you can go around from up top and try to get in that way, or you can come from the arm and try to get in the top that way. And so you have three options, three ways to try to connect the dots there between the open aorta and the open femoral artery down below. And I would exhaust all of those before I would either try to do an open aortic based repair or an open fem-fem.
Oh, wow. Well, any final thoughts on the Fem-Fem? It sounds like there might be, at least something to have a productive discussion with the doctor, prior to having a Fem-Fem.
Yeah, I mean, I would always ask about, how long do we expect this to stay open? If and when it goes down, then what are we going to do, right? And if you're looking ahead, if I think about this operation very differently in somebody who's 60 than in somebody who's 80. Just because again, somebody who's 60, I expect to be alive when that bypass goes down. So then what are we going to do? The patient is now older and may have more medical problems, more issues, right? We're going to have to come up with something. So what is that and what's our plan?
Yeah, I love that. What is the contingency plan? Thank you so much, Dr. Lily Johnston. You got to subscribe to our YouTube channel, youtube.com/the @ sign at Lily Johnston MD, and youtube.com/the @ sign at, right, the way to my heart. That's our YouTube channel as well. Make sure you subscribe to both channels and have a great day.
Thanks, Kim.